Hi friends and welcome to this session. So today we'll be discussing about posterior malleolar fractures. Very often asked question in your exams, theory as well as practicals. As a part of ankle fractures, we have seen this quite many times in the numerous lectures that we have taken. Just thought highlight or reinforce the same things rather. Okay. So posterior malleus was described way back in 1932. The importance of the structure and what all things are attached. Okay, and it was described as an articulating surface of the tibia. So the any fractures which involves articular surface is definitely important because it directly has a bearing on the functional aspects of that particular joint. If you look into the overall fractures ratio, about 65% of them are isolated malleus. So mostly it is the isolated lateral malleus fractures, could also be isolated medial malleus rarely. Okay. 1/4 are bimallear. So 90% of the ankle fractures don't involve the posterior malleoli, but about 7% are trimallear in the sense they involve posterior malleoli. And this is where we need to focus on and see if it's involved, and if it's involved, what is the particular pattern and whether it requires surgery or not, because that decides the ultimate functional outcome of a patient. Okay. Isolated posterior malleolar fractures do occur, but it's pretty rare. But the treatment principle will remain same. Now, if you look into the anatomy, what is attached, this big triangular chunk of bone is the posterior malleoli. As we can see, this particular ligament is the posterior inferior tibia. So tibia to fibula, posterior inferior tibiofibular ligament is this ligament, and then we have the interosseous ligament going into the syndesmosis. So this entire structure use are syndesmotic ligaments and give integrity to the syndesmosis. So that's why it is very, very important. And treatment, if you look what how things have changed, for a significant period of time, it was thought that posterior malleolar fractures are not very important from treatment perspective, and it doesn't need to be treated as long as it is less than, as long as it's more than 1/3. Okay, if it's only, it has to be treated only if it is more than 1/3 the diameter of the distal tibia. But how did that come? That is because of this particular article 1940, in which they studied 8 cases and showed that as long as the fracture is lesser than 1/3, it doesn't have any functional bearing on the joint. So it is, they call those minimal fractures. Okay, so this could simply be reduced and held with a cast. We don't need to internally fix them. So this was way back in 1940. Now, remember at this time, number one, fractures, most of them do not even undergo CT scan. Number two, biomechanical studies was not there, and even long-term follow-ups was not that very particular regarding to most issues that we are aware of as of today. Okay, but thing was, this particular notion of treating or not treating, depending on the size of the fragment, it is 1/3, stood a significant period of time. And even in now, some books unfortunately stick on to that fractures don't need to be treated unless it involves more than 1/3 the articular surface. Now, this statement is not valid. Okay. Now, from 1/3, it became 1/2. In the sense, Harper and colleagues, they showed that as long as, so what they did was they transected the posterior malleoli, 50% of the articular surface, and then saw what happens, whether the talus subluxated or not. Now, they proved that even if 50% of the articular surface posteriorly is transected and removed off, the talus did not have a posterior subluxation. Now, this was very confusing, but what was neglected by many people, that this is only true if the fibula is intact and there is no disruption of the lateral ligamentous structures. That means the anteroinferior tibiofibular ligament. Like, most of them focused on the results rather than what was excluded. So what they told was, if we only transect and remove the posterior malleolar chunk of bone, now, for example, in this category study they had done, where they cut off the posterior fibular bone and tried to load the joint and saw that the talus subluxated, it did not. Okay. So as we can see, this much amount of triangular bone is being removed. So that is more than about 50% of the bone is being removed. And even then talus is not subluxed. They were trying to load the joint, trying to push the tibia forward and talus, the ankle, the hind foot posteriorly. But even then the talus is not subluxating posteriorly. This is true. But the thing was, they did not do anything anteriorly. They just took off this bone. The fibula was intact and anteroinferior tibiofibular ligament was intact. So their conclusion was, as long as those structures are intact, even up to 50% of posterior malleolar fractures need not be fixed. We need not worry about the stability concerns. Okay. Now, the second part was somehow missed, and many of them started telling up to 50% of the fracture, up to one half of the distal tibia we don't need to fix. So that's only partially true. So that's what this nice study showed 2016, that if you look into the ankle stability, 40% is provided by the posterior inferior tibial ligament, 35% by the anterior inferior tibial ligament, and 22% by interosseous ligament, right? So if the anterior is intact, fibula is intact, maybe yes, posterior doesn't play such a significant role. But when does posterior malleolar fracture? In most cases, posterior malleolar fractures after the fibula fracture and the anterior fracture. So in that case, if the posterior malleolar is fractured, it is already known that the anterior structures are gone. In that case, posterior malleolar fixation becomes mandatory, because otherwise the stability of the ankle joint is lost, right? So that's what we need to understand. Now, coming to classification, again, different books give different systems. The most commonly used are Haraguchi and Bartonesek. Now, this is the Haraguchi classification. Pretty simple: type 1, type 2, type 3. Type 1, we have big chunk, the oblique post. So this is type 1. Type 2 is posterolateral with the posteromedial. So posterolateral with the posteromedial is type 2. So the fracture is extending into the posteromedial zone. And type 3 is one small flake of bone, right? And the importance of this system was type 1 requires fixation, type 2 requires fixation, and type 3, this is too small a bone, so it can be omitted from surgical intervention. But again, remember, this system, again, although good descriptive system, falls back on the size of the fragment, telling that this is a very small fragment, can be neglected, whereas this is a big fragment, needs to be fixed, okay? So we cannot have a system based on the size, because now in posterior malleolar, size is not concerned. So what is more suitable, more relevant is this Bartonesek classification. This was in 2015, where they proposed a system of classifying posterior malleolar fractures. So there are 5 types: type 1, 2, 3, and 4. In type 1, as we can see, it's a very, very small flake of bone, but that is not what it is. Any fracture on the CT which doesn't extend into the distal tibiofibular joint. Now, if this is the distal tibiofibular joint, the fracture stops short of entering that joint. Now, if you see this fracture is entering this joint. Similar, this fracture is entering this joint. Fracture is entering this joint. So this fracture stops short of the incisura, and those fractures do not have much bearing on the stability of the joint, and these can be called as the type 1 fracture, immaterial of the size. Most of these cases, it will be a small flake of bone, like what is seen on the X-ray, right? But again, remember, all of these CT becomes mandatory, because all these classifications are CT based. In type 2, it is the posterolateral fragment, okay? So isolated involvement of posterolateral is type 2. The type 3 is posterolateral with posteromedial. So posterolateral and posteromedial, that is type 3. A type 4 is a large posterolateral. Now, this particular subset is totally different from this one, in the sense that these ones usually can occur as a part of ankle injuries, but are also seen as part of pilon fractures. Okay, these large posterolateral fragments. So this is type 4. And then we have a type 5. It is basically irregular pattern, that it doesn't fall into any one of these, or a fracture with an osteoporosis. Now, why is that important? Is that when you have an osteoporosis, now internal fixation of that particular fragment becomes difficult. Whatever implant we put in might not have adequate purchase. So that's why that becomes a type 5. So type 1, flake not extending into the joint, the distal tibiofibular joint, the incisura. Type 2 is posterolateral, type 3 is posterolateral with posteromedial, and type 4 is a large posterolateral, large triangular posterolateral. So can be seen as part of ankle or also in pilon fractures. Now, that is Bartonesek classification. Now, some books mention about Mason's classification, which is this, and also asked in few papers which was augmented. But actually, this is nothing but the same reprint version of Bartonesek, where they slightly modified things. Okay, now this came out in 2017.